So from a clinician point of view, I think education is very important in trying to identify those patients. Again, like I mentioned, maybe we need a change in the algorithms and really have an early identification way, a way to early identify these patients to see if they can benefit from IV treatment early on, 1 or 2 doses. Fine, and then having a landscape where maybe we don't need an inpatient setting, but we don't need a maybe clinic setting either. Like maybe a halfway point would be better to assess these patients, monitor them while these doses are being given, and then trying to see if we can finish out the treatment course with some of the oral antibiotics. Some of the longer lasting agents, like I had mentioned, the lipoglycopeptides, they're really changing the landscape. We're seeing more and more use of dalbavancin and iridovancin for ABSSSI, and it's very helpful because of a coverage point of view, compliance point of view, the patients are able to get this dose very quickly and move on with their lives, and then have them just making sure we have a follow-up with those with that. And then even though these agents are FDA approved for ABSSSI, there is more and more evidence that's coming forward for their use in maybe other indications and other infections, which in general will decrease their length of stay in the inpatient setting and have more options for patients that are walking and talking and they're not really fit for the hospital, but they still have that infection to deal with.